Welcome to the deep dive. Today, we're jumping into Turner syndrome.
That's right.
We're aiming for a really clear, kind of high-yield guide here, something that helps you understand this condition which affects females.
hmm We've boiled down the notes to the essentials.
Exactly. Just a straightforward, memorable overview, perfect if you're revising. Our mission really is just to make Turner syndrome clear and help it stick, ready to explore.
Absolutely. Let's start with the basics. The definition.
Okay.
So Turner syndrome, you might see it written as 45X or monosomy X. It's a genetic condition, specifically in females.
Right. Females only.
And the key is that one of the X chromosomes they normally have, XX, is either completely missing or it's incomplete, abnormal in some way.
Got it. So missing or faulty X chromosome.
Precisely. And that missing genetic information, well, it triggers various developmental and physical characteristics.
Okay, so it all stems from not having that standard pair of X chromosomes.
Yeah.
And you mentioned the prevalence. It's not super rare, is it?
It's estimated around 1 in 2,000 to 1 in 2,500 live female births. So, yeah, it's something clinicians encounter.
Definitely something to be aware of then. And the core features seem to be things like short stature.
Yes, that's very common. Also, ovarian failure, or at least issues with ovarian function.
Okay. And other health problems too, potentially.
That's right. There's an increased risk for several things.
Like what specifically?
Well, while general intelligence is usually completely normal, there can be some specific learning differences, maybe challenges with nonverbal cues, social skills, or even psychomotor coordination.
Okay, so subtle differences sometimes?
Sometimes, yeah. And physically, there's a higher risk for things like congenital heart defects. So heart problems present right from birth, also hearing loss, sometimes obesity and diabetes later on.
Right. Quite a range of potential issues. Okay, let's move on to the why. What's the etiology? What actually causes this chromosome difference?
The fundamental cause, as we said, is that complete or partial absence of one X chromosome in the cells.
Well, how does that happen?
It's usually down to a random error. Something goes slightly wrong during the formation of the egg cell, or maybe in the very early cell divisions just after fertilization.
So like a mistake in the copying process almost.
You could think of it like that. A random event during meiosis or early mitosis. It's not usually something inherited.
Okay, that was my next question. It's typically sporadic then, not passed down.
Exactly. It's generally a one-off, a new occurrence in that individual, not something you typically see running in families.
Good to clarify. And what about risk factors? Is there anything that makes this random error more likely, like parental age or lifestyle?
Well, this is interesting. Generally, there are no specific known risk factors. It doesn't seem linked to parents' health or what they do.
Really?
Yeah. Now, one part of the notes briefly mentioned a possible slight increase with advanced maternal age, but, well, the epidemiology data doesn't really support that strongly.
Okay, so the consensus is basically no clear risk factors.
Pretty much. We
Well,
consider it a random, spontaneous event for now.
right. So mostly chance. Now, how does this missing chromosome actually affect the body? What's the pathophysiology, the mechanism behind the features?
Okay, so the core problem is that missing or abnormal X chromosome. That chromosome carries crucial genes, instructions for development.
Right.
When those instructions are missing or altered, it disrupts normal growth and development right from the start. A really key consequence is a hormone imbalance,
Hormones, which ones?
primarily estrogen. The ovaries often don't develop or function properly, leading to low estrogen levels.
And that explains things like,
Exactly. It's a major factor behind the short stature, the delayed or absent puberty, and the reproductive issues, like infertility.
makes sense.
And this genetic difference doesn't just affect hormones. It can impact how various organ systems develop too, like the heart, the kidneys.
So it's quite systemic.
It can be, yes. Though it's fair to say the exact step-by-step ways these genetic changes lead to all the features. Well, that's still being researched. We don't understand every single molecular detail yet.
Yeah, understood. Still some unknowns. Okay, so if a clinician suspects Turner syndrome, what else might be on their list? What's in the differential diagnosis?
Good question. There are several things to consider, conditions that might share some features.
Such as?
Well, growth hormone deficiency is one, because that also causes short stature.
Okay.
Primary ovarian insufficiency, for other reasons, could present similarly in terms of ovarian function.
Right.
You'd also think about other chromosomal disorders just generally, and specifically Noonan syndrome that can have overlapping physical features, like the web neck sometimes.
Noonan. Okay, got it.
Anything else?
maybe Klinefelter syndrome, although that affects males and involves an extra X. It's still a chromosomal condition you might consider in the broader context of developmental variations.
Okay, so a few key conditions to rule out or consider. Let's shift to the bigger picture again, epidemiology. How common is this really? We touched on birth prevalence. Yeah, the estimates vary slightly, but generally 1 in 2,000 to 1 in 5,000 live female births. It's definitely one of the more common chromosomal disorders found in females.
And what about in the wider population of women?
The prevalence there is estimated a bit lower, maybe 25 to 210 per 100,000 women.
Why the difference compared to births?
It reflects that, unfortunately, a very high percentage of pregnancies conceived with the 45X karyotype don't survive to term. Estimates suggest maybe 1–2% of all conceptuses are affected, but only at 1% of those make it to a live birth.
Wow, okay. That's a significant loss.
It is. Another important point in epidemiology is mosaicism.
Mosaicism meaning?
Meaning not all cells in the body have the same chromosomal makeup. Someone might have some cells that are 45X, but other cells could be the typical 46XX or even 46XY in rare cases.
Ah, like a mix of cell types.
Exactly. And that mosaicism can influence the severity and range of clinical features someone experiences.
That makes sense why there's variability. And just to circle back and be really clear, advanced maternal age.
Not considered a risk factor. Despite that one brief mention we saw, the overall epidemiological evidence points away from it. It's a random event.
Okay, crystal clear now. Random event, not linked to maternal age. Let's get into the specifics of what someone might present with. The clinical features. What do you actually see?
Right. The signs and symptoms, they can be quite varied, as mosaicism suggests, but there are common themes.
Any way to remember them easily?
Well, I sometimes think of a rough mnemonic, though it's a bit clunky. Like short webbed neck and broad chest, low ears and lymphedema, reproductive issues and heart problems, kidney trouble, learning differences, pigmented spots and hearing problems, low hairline and eye issues.
Haha. Okay, a bit of a mouthful, but captures a lot. Let's break that down. Short stature.
Definitely. That's almost universal. Delayed growth and delayed or absent puberty are also very common.
And the physical signs. You mentioned neck, chest.
Yes, a classic sign can be a webbed neck, extra skin folds.
Yeah.
Also a broad chest, sometimes with widely spaced nipples, low set ears. Lymphedema is another key one, especially noticeable in newborns, swelling, puffiness, often in the hands and feet.
Ah, swelling at birth.
Then the reproductive abnormalities, specifically ovarian dysgenesis or failure, leading to infertility in most cases.
Right, a major impact. Heart problems.
Very important. Things like a bicuspid aortic valve, the main heart valve having 2 flaps instead of 3, and coarctation of the aorta, a narrowing of the big artery leaving the heart. These need careful checking.
Definitely sounds critical. Kidneys, too.
Yes. Kidney malformations can occur, like a horseshoe kidney where they're fused, or sometimes one kidney might be missing renal agenesis.
Okay. What else from your mnemonic learning spots?
Right. Some individuals might have learning disabilities, often more with nonverbal reasoning or spatial awareness than verbal skills. You might see lots of pigmented nevi moles.
Moles. Okay.
Hearing problems are common too, both potential hearing loss and recurrent ear infections, like otitis media.
Ear infections, right.
And then a low hairline at the back of the neck, and eye problems, things like strabismus, crossed eyes, amblyopia, lazy eyes, sometimes even cataracts.
Wow, okay, so it really can affect multiple systems. That mnemonic, short, webbed neck, that's actually quite helpful to remember the clusters.
It covers the main ones, yeah.
So with this constellation of possible features, how do you actually confirm the diagnosis? What investigations nail it down?
The absolute definitive test is karyotype analysis.
The chromosome check.
Exactly. A blood sample is taken, and the chromosomes are examined under a microscope. That will clearly show the 45X pattern or other related X chromosome abnormalities like mosaicism or deletions.
Okay, that's the gold standard. What about before birth or other supporting tests?
Prenatally, ultrasound findings might raise suspicion. Things like a cystic hygroma, that fluid-filled sac on the neck we mentioned, or generally thick neck tissue, lymphedema, or the fetus just being small for gestational age.
So ultrasound can give clues after birth.
After birth, besides the karyotype, an echocardiogram, an ultrasound of the heart, is crucial to check for those cardiac anomalies.
Essential, given the risks.
Definitely. Hormone level tests are useful too, checking LH, FSH, which are often elevated due to the ovarian issues, and also thyroid hormones, as thyroid problems are more common.
Okay, hormone checks.
Renal function test, blood and urine tests to check the kidneys. A bone age assessment, usually an X-ray of the hand and wrist, helps gauge growth potential and plan growth hormone therapy.
Bone age X-ray, right.
In adults, bone density testing might be done to screen for osteoporosis. Regular hearing tests are vital, and genetic counseling is really important throughout.
Genetic counseling for implications and support.
Yes, to explain the diagnosis, discuss what it means for the individual and family, talk about management, future options, and reinforce that it's usually not inherited.
Okay, quite a comprehensive workup. So once the diagnosis is confirmed, what's the general approach to management? It sounds like it needs to be ongoing.
Absolutely. It's a lifelong condition, and management needs a multidisciplinary team. Lots of different specialists involved.
Who's typically on the team?
Endocrinologists, cardiologists, gynecologists later on, perhaps urologists, audiologists, ophthalmologists, psychologists, dentists. It depends on the individual's specific needs.
Right. And the focus is?
The main goals are regular screening for associated conditions, prevention where possible, and early treatment of any problems that arise. There's a big emphasis on monitoring heart health.
Because of the cardiac risks.
Exactly. And beyond that, focusing on optimizing growth, supporting pubertal development, addressing fertility options, and just maintaining overall health and well-being.
Can we break down some specific management areas? Like, what do the pediatricians and endocrinologists focus on?
Sure. They're key for monitoring growth very closely, managing growth hormone therapy if needed. They also oversee pubertal induction using estrogen replacement. Plus, regular checks for thyroid function, screening for celiac disease, and advising on bone health to prevent osteoporosis later.
Okay, growth, puberty, thyroid, bone health. What about eyes and ears?
Ophthalmology does regular checks for things like amblyopia, strabismus, and other potential eye issues. ENT ear, nose, and throat specialists monitor hearing closely and manage recurrent ear infections like secretory otitis media or glue ear.
Glue ear, right. Dental care.
Important, too, as teeth crowding or malocclusion can happen. Regular dental checkups are needed. Usually, antibiotic cover before procedures isn't necessary, unlike some other conditions.
Good to know. Orthopedics.
Generally, regular ortho reviews aren't standard unless specific bone or joint problems pop up.
And cardiology and urology sounds like they need regular input.
Definitely. Cardiology involves periodic evaluations, often with echocardiograms, maybe cardiac MRI sometimes, to monitor the aorta and valves. Urology means annual kidney function tests, checking electrolytes, maybe urine cultures to check for infections.
And you mentioned genetic counseling and psychological support.
Yes, both vital. Counseling provides information and support, stressing the non-inherited aspect usually. Psychological support helps with adjusting to the diagnosis, managing any learning or social challenges, and promoting overall well-being.
It really is a whole-person, lifelong approach. What about specific treatments like hormones?
Growth hormone therapy is standard practice to improve final height, often started in childhood. Then, hormone replacement therapy, usually starting with estrogen, is needed to induce puberty and maintain female secondary sexual characteristics, and also for bone health.
And fertility.
That's a sensitive area. Because of the ovarian failure, natural conception is very rare. Options like using donor eggs with IVF are often discussed for those who wish to have children.
Okay, so summing up management. It's individualized, needs that whole team, there's no cure per se, but therapies like growth hormone and estrogen replacement make a huge difference to development and quality of life.
That's a great summary. It's about managing the symptoms and associated conditions proactively.
Now, thinking long term, what's this prognosis generally like for individuals with Turner syndrome?
It really does vary quite a bit, depending on the severity of any associated health issues, especially heart problems, and how well everything is managed.
So early diagnosis and good care are key.
Absolutely crucial. With that comprehensive, proactive care, many individuals lead fulfilling, productive lives. However, we do know that short stature, even with growth hormone, is common, and infertility remains a major challenge for most.
Right. Are there increased health risks long term?
Yes, unfortunately, there is an increased risk of mortality compared to the general female population. This is largely due to cardiovascular complications like aortic dissection or heart disease, but also potentially other issues. That just underlines why lifelong monitoring is so important.
Okay, so a generally positive outlook with good care, but with those caveats about infertility and the need for vigilant long-term health monitoring, what are the main complications to watch out for?
Well, we've touched on many already. Infertility is probably the most common complication due to the ovarian issues.
Right.
Cardiovascular abnormalities are a major concern. Coronary artery disease, hypertension, stroke risk, aortic dilation or dissection.
Serious risks there.
Yes, kidney problems can persist or develop. Thyroid disorders, particularly hypothyroidism, are quite common. Hearing loss can progress.
Okay.
Learning difficulties, especially nonverbal ones, might persist. And osteoporosis is a risk later in life due to the estrogen deficiency if not managed well.
So quite a list, reinforcing that need for regular checkups across different specialties.
Exactly. Regular monitoring and interventions for these potential complications are fundamental to good long-term care.
This has been incredibly thorough. It feels like the key takeaways are understanding the genetic basis, that 45X or variant, recognizing those key features, maybe using that mnemonic.
The short web neck one.
Yeah, knowing the crucial investigations like karyotyping and echo, and appreciating the really comprehensive, lifelong, multidisciplinary management needed.
That sums it up well. Early diagnosis and that team approach really are central to improving outcomes.
It certainly highlights how understanding specific genetic conditions can make such a difference to individual lives, and how healthcare needs to be organized to support them. It's something to think about, isn't it? The wider impact of genetic knowledge.
Definitely food for thought.
Well, this has been a fantastic deep dive. For everyone listening, if you want to consolidate this and test your knowledge, especially for MSRA prep, do check out passmsra.com and also freemsra.com. They've got some great resources.
Excellent resources for revision.
Thanks so much for joining us for this deep dive on Turner syndrome.